In this module, we are going to cover transfusion transmissible infections, often abbreviated to TTIs, and donor counseling. A transfusion transmissible infection is an infection that can be passed from person to person through parenteral administration of blood or blood products. Examples of known major TTIs include Hepatitis A, B, C, D, and G, human immune virus or HIV, human T-cell polytrophic virus, that is, HTLV1 and 2, West Nile virus, syphilis, Zika virus, and malaria. The World Health Organization recommends that all donated blood is tested for at least 4 infections to make blood transfusion a safe procedure. These are HIV, Hepatitis B virus, Hepatitis C virus, and syphilis. Therefore, it is these TTIs that will be the focus of this module. Malaria accounts for many deaths in Africa. The Eastern Mediterranean, Western Pacific, and Ibero-American countries are also at risk. Screening guidelines for accepting or deferring donors who have been to endemic areas are in place in most countries of the world to minimize transmission of malaria through blood transfusion. Despite this, discussion of malaria in this module will be limited. Although WHO guidance states that all donated blood should be tested for malaria where appropriate and possible, the reality is that malaria screening is not performed in most malaria endemic countries in sub-Saharan Africa. There are several reasons why screening for malaria is problematic. Severe blood shortages are widespread and will be exacerbated by rejecting blood that contained malaria parasites. Also, most malaria tests are not sensitive enough to detect low levels of parasites, and there is no evidence-based guidance to indicate which malaria screening methods are effective in malaria endemic zones. Finally, it is unclear what action should be taken if the donated blood tests positive. Some countries with malaria-free regions, such as Namibia, take steps to ensure that blood collected from malarial areas is only transfused locally. But for most African services, transfusion-transmitted malaria is irrelevant because of the overall prevalence of the disease. There are 4 learning objectives in this module. By the end, you will have an understanding of the main TTIs and donor counseling approaches. This will help in your day-to-day work, enabling you to answer basic questions from the public and recruit safer donors. We will begin by looking at HIV/AIDS. The human immunodeficiency virus is the virus that causes acquired immune deficiency syndrome or AIDS. There are 2 types of HIV, HIV-1 and HIV-2. The HIV virus is believed to have originated from Central Africa and to have been spread by chimpanzees. According to UN/AIDS data, more than 37.9 million people were infected with HIV globally at the end of 2018. Around 35 million people have died from HIV-related illnesses since the beginning of the epidemic. An estimated 0.8% of adults aged 15 to 49 years worldwide are living with HIV. According to the WHO, the Africa region remains the most severely affected, with nearly 1 in every 25 adults, 4.1% of the population, living with HIV and accounting for nearly 2/3 of the people living with HIV worldwide. When HIV infects a host CD4 cell, it attaches to and fuses with this host cell in order to be able to reproduce. Once fused and in the cell, the single-stranded RNA of HIV is converted into the double-stranded DNA. It accomplishes this with the help of an enzyme called reverse transcriptase. Once converted to DNA, viral replication takes place. In order for HIV to hijack the host cell's genetic machinery, it must integrate the newly formed DNA into the nucleus of the cell. Once integration has occurred, HIV produces proteins that it uses to assemble new viruses. It does so with the protease enzyme, which breaks protein into smaller bits and then assembles the pieces into new fully formed HIV virus. The process is repeated over and over until the immune system is weakened. There are several ways in which the HIV virus can be spread. However, transmission is mostly through having unprotected sexual contact with an infected person, having multiple sex partners, or the presence of other sexually transmitted diseases, or STDs, can increase the risk of infection during sex. Unprotected oral sex can also be a risk for HIV transmission, but it is a much lower risk than anal or vaginal sex. Sharing needles, syringes, or other equipment for unprescribed drugs also spreads the HIV virus. An infected mother can pass on the infection to her child during pregnancy, birth, or breastfeeding, and receiving a blood transfusion, blood products, or organ or tissue transplants that are contaminated with HIV can also spread the virus. Diagnosis of HIV infection at any age requires diagnostic testing that confirms the presence of the HIV virus or antibodies. Serological testing identifies HIV antigen and/or antibody generated as part of the immune response to infection with HIV. The ELISA test is one of the most effective tests used for donated blood. Rapid diagnostic tests, or RDTs, which detect the presence of HIV antibodies, can also be used. Rapid tests provide same-day test results, which are essential for same-day diagnosis and early treatment. Nucleic acid testing is the gold standard for detecting the HIV virus. It reduces the window period in donated blood to between 5 and 7 days. The nucleic acid test detects the actual virus in the blood. Oral swab tests can also detect antibodies if a person is infected. However, it needs to be confirmed. During the primary stage, some people experience flu-like symptoms within 2 to 4 weeks after contracting the HIV infection. These symptoms are the body's natural response to the virus. Symptoms can include fever, enlarged lymph glands, headache, sore throat, aches and pains, or night sweats. People who have contracted the virus are highly infectious at this early stage because of the high levels of HIV in their blood. The CD4 levels drop fast as large amounts of the virus proliferate in the bloodstream. During the latency or asymptomatic stage, the virus is active but reproduces at very low levels. At this stage, there are usually no symptoms. With treatment, one may remain in this stage for a long time, with therapy reducing viral activity. Without treatment, the clinical latency stage lasts between 5 to 10 years. Treatment can reduce the level of the virus to such an extent that it is undetectable. This means that the body remains healthy and chances of transmitting the virus are low. Without treatment, the viral load continues to increase whilst the CD4 cell count drops. The weakened immunity leaves the body susceptible to various infections and diseases, which can be life-threatening. Symptoms at this stage vary greatly as they tend to be associated with various opportunistic infections. Some of the more common symptoms include pneumonia, tuberculosis, chronic diarrhea, swollen lymph glands, and some types of cancer. The most effective way of slowing progression of the disease is to take anti-retroviral medicine. The sooner diagnosis occurs, the sooner treatment can start, and the greater the chance of enjoying a normal or near-normal lifespan. Early diagnosis also lowers the risk of transmitting the virus to others. This treatment is beneficial at all stages of the virus. The medicine suppresses the amount of virus in the blood, thereby strengthening the body's immune system. Pre-exposure prophylaxis preventive medication is available for those who do not have the virus but have a higher risk of contracting it. One pill is taken daily. Post-exposure prophylaxis is treatment given to someone who has accidentally been exposed to HIV within the previous 72 hours. The aim is to stop infection with the HIV virus. The most reliable way to avoid infection with HIV is to avoid unprotected sexual intercourse with an infected partner. However, the consistent and correct use of condoms also reduces the chance of becoming infected. Also reducing the possibility of contracting HIV are abstinence, that is, not having sex, limiting the number of sexual partners, and never sharing needles or syringes. Taking post-exposure prophylaxis soon after accidental exposure is highly recommended, as in certain circumstances, is pre-exposure medicine to avoid being infected. Hepatitis B is inflammation of the liver caused by the Hepatitis B virus, or HBV. The incubation period of the Hepatitis B virus is from 30 to 160 days. Most people infected recover completely, but a few continue to carry the virus in their blood, even though they look and feel well. During this time, they are carriers of the virus and can spread it to other people. A positive hepatitis B surface antigen test tells that you have been exposed to the hepatitis B virus. However, the test does not tell whether you have a recent or old infection. If you have a positive test result, you should contact your doctor who will assess the state of your liver and determine whether additional tests are needed. Some results of the tests determine your level of infectivity, how often you have to be seen, or whether you can benefit from treatment. Hepatitis B virus is spread when blood or other body fluids from an infected person enters the body of a person who is not infected through direct contact with open sores or abrasions of an infected person. Sharing of razor blades, sharp piercing objects, toothbrushes or needles and syringes also puts one at risk of being affected, as does needle stick injuries or transfusion with infected blood or blood products. Sexual transmission of hepatitis B may occur with multiple sex partners or contact with sex workers, leading to increased risk. An infected mother can pass on the virus to her baby during pregnancy or during delivery. The hepatitis B virus can survive outside the body for at least 7 days. During this time, the virus can still cause infection if it enters the body of a person who is not protected by vaccine. Signs and symptoms of hepatitis B range from mild to severe. They usually appear after 1 to 4 months, although can be seen as early as 2 weeks post-infection. In mild cases, 70% of those infected do not show signs or symptoms. However, some can have the following symptoms: nausea and vomiting, fever, itchiness of skin, abdominal pain, loss of appetite, fatigue and joint pains. Severe cases will have the following symptoms: dark urine, clay-colored feces, hepatomegaly or enlargement of neck lymph nodes. There are several blood tests that can be carried out to establish if a person has hepatitis B infection. Serological tests to check for hepatitis B surface antigen can be done to detect the presence of the hepatitis B virus. Liver function tests can tell your doctor whether your liver is working properly, and they can also use it to monitor your condition during treatment. Ultrasound scan or X-rays can also be carried out to assess the state of liver fibrosis. You may need a liver biopsy. During a liver biopsy, a small piece of the liver is removed and examined under a microscope. The likelihood that infection becomes chronic depends on the age at which a person becomes infected. Children less than 6 years of age who become infected with the hepatitis B virus are the most likely to develop chronic infections. In infants and children, 80 to 90% of infants infected during the first year of life develop chronic infections, and 30 to 50% of children infected before the age of 6 years develop chronic infections. In adults, less than 5 to 10% of otherwise healthy persons who are infected as adults will develop chronic infections, and 20 to 30% of adults who are chronically infected will develop cirrhosis and/or liver cancer. Patients with chronic HBV infection can benefit from antiviral medication. This is not a cure, but it can stop the virus from replicating and prevent its progression into advanced liver disease. There is no specific treatment for acute hepatitis B. Therefore, care is aimed at maintaining comfort and adequate nutritional balance, including replacement of fluids lost from vomiting and diarrhea. Chronic hepatitis B infection can be treated with medicines, including oral antiviral drugs such as tenolam or interferon alpha-2b. Treatment can slow the progression of cirrhosis, reduce incidence of liver cancer, and improve long-term survival. Persons with chronic HBV infection require ongoing medical evaluation of the liver every 6 months to monitor for liver damage or worsening disease. An individual diagnosed with hepatitis B should seek medical attention early and follow any advice given. They should be cautious about alcohol, since drinking too much is harmful to the body, especially the already diseased liver, and can lead to more severe liver problems. Infected individuals should avoid taking drugs which are not prescribed by a doctor, as some drugs have very serious effects on the liver. Also important is avoiding transmitting the virus to others by practicing safer sex and avoiding sharing hygiene equipment like razor blades and toothbrushes. Pregnant women infected with the hepatitis B virus should seek advice from a doctor or counselor. Pregnant women frequently transmit the disease to their babies, so it is advisable to be tested early in pregnancy. If the blood test is positive, the baby should be vaccinated immediately after birth. The following should be vaccinated against hepatitis B: all babies and children below 19 years, persons with clotting disorders, household contact and sexual partners of persons with hepatitis B, and anyone else at high risk of infection. In addition to vaccination, implementation of blood safety strategies, including quality-assured screening of all donated blood and blood components used for transfusion, can prevent transmission of HBV. Safe injection and safer sex practices, such as minimizing the number of partners and using condoms, can also offer protection. Hepatitis C is inflammation of the liver that is caused by the hepatitis C virus. The WHO recommends testing for hepatitis C in donated blood in order to prevent transmission through blood transfusion. The virus can cause both acute and chronic hepatitis, ranging in severity from a mild illness lasting a few weeks to severe chronic infection. The incubation period ranges between 15 to 160 days. There is no vaccine for hepatitis C. The hepatitis C virus is mostly transmitted through exposure to infected blood. This may happen through patients receiving a transfusion of HCV-contaminated blood and blood products, using contaminated needles, and infected mother-to-child transmission. Sexual transmission is also possible, but is much less common. The majority of those affected do not show signs and symptoms. However, others experience signs and symptoms similar to other viral hepatitis infections. They can experience flu-like symptoms, abdominal pain in the liver region, fever, jaundice, dark urine, nausea and vomiting, fatigue and joint pains. There are several tests that can be done to establish a hepatitis C virus infection diagnosis. Testing for anti-HCV antibodies with a serological test identifies people who have been infected with the virus. However, the test does not distinguish between old and current infection. If the test is positive for anti-HCV antibodies, a nucleic acid test for HCV ribonucleic acid, or RNA, is needed to confirm chronic infection. This is because about 25 to 30% of people infected with HCV spontaneously clear the infection from their system. They will, however, still test positive for anti-HCV antibodies. Other tests that can be done to assess the extent of fibrosis of the liver are ultrasound scan or liver biopsy. Hepatitis C virus causes both acute and chronic infection. New HCV infections are usually asymptomatic. Some persons get acute hepatitis C infection. In approximately 20% of cases, the virus spontaneously clears within 6 months of infection without any treatment. The remaining 80% will develop chronic HCV infection. Of those with chronic HCV infection, the risk of cirrhosis or cancer of the liver ranges between 20 and 30% within 20 years. Currently, the test for hepatitis C, routinely used for screening donated blood, is an antibody test. This test shows whether or not a person has been infected with the hepatitis C virus. However, it does not distinguish between recent and old infection. In addition, the test does not differentiate between persons who are infectious and those who have completely recovered and cannot now pass the infection to anyone else. A donor screening positive for HCV requires additional tests to determine whether they are still infectious or have completely recovered. Treatment for hepatitis C involves using medications to control symptoms of the infection, as well as drugs that can help cure the infection itself. Using medications may improve the outcome of the disorder by helping to prevent severe complications from chronic liver damage. In the past, there were not many medical treatments available to treat hepatitis C. Today, however, there is a variety of antiviral drugs that are used for treatment. Drugs such as ribavirin and tenofovir can be used to slow down progression of the disease. In the case of a diagnosis of hepatitis C, medical attention should be sought early and all advice followed. As with HBV, infected individuals should be cautious about alcohol and non-prescription drugs. they should eat well, practice safer sex, and avoid sharing hygiene equipment. There is no vaccine against hepatitis C, so primary prevention involves non-infected individuals avoiding contact with blood from someone who is infected. Infected persons should not, of course, donate blood or organs and should ideally be identified and deferred at the screening stage. But implementation of blood safety strategies, including quality-assured screening of all donated blood and blood components used for transfusion, can help prevent the infection of patients. Similarly, safe injection practices can be effective, so can safer sex practices, since minimizing the number of sexual partners and using condoms consistently offers good protection. Syphilis is a sexually transmitted disease caused by bacteria or germs known as Treponema pallidum. It is spread by direct contact with a syphilis sore during vaginal, anal, or oral sex. The sores can develop on or around the penis, vagina, or anus, or in the rectum, on the lips, or in the mouth. Syphilis can also spread from an infected mother to her unborn baby. The incubation period for syphilis is 10 to 21 days on average. There are several tests that can be done to detect syphilis. Blood tests can confirm the presence of antibodies that the body produces to fight infection. The antibodies to the bacteria that causes syphilis remain in your body for years, so the test can be used to determine a current or past infection. If a sore is present, a sample can be taken from the sore to determine if the syphilis bacteria are present by carrying out a physical examination. VDRL, RPR, TPHA, or rapid syphilis tests can variously be conducted. Primary syphilis usually presents itself as a single sore. This sore typically appears 3 weeks after the initial infection, but could show as soon as 10 days or as late as 90 days. The sore is small, firm, round, and painless. It appears at the original infection site, usually the mouth, anus, or genitals. Untreated, the initial sore heals in a month or so. The symptoms of secondary syphilis develop 2 to 8 weeks after a person first becomes infected with primary syphilis, and a non-itchy rash usually marks this stage. The rash might be confined to one part of your body, or it could spread over several parts. The appearance of the rash varies. A non-itchy rash usually appears all over the body, especially palms of hands and soles of feet. Other symptoms include patchy hair loss from scalp, eyebrows, and pubic hair, headache, weight loss, and mild fever. The latent stage of syphilis is the period of time when there are no visible signs or symptoms of syphilis. If the disease is not treated, one can continue to have syphilis in the body for years without any signs or symptoms. Untreated syphilis can affect any part of the body. When it affects the heart, it can damage heart valves, leading to heart failure. In the brain, it leads to a form of madness and abnormal walking gait. Syphilis in the eyes can lead to blindness. When it affects bones and joints, syphilis deforms them and they become weak and easy to break. In pregnancy, syphilis can cause abortions and sometimes death of the unborn baby. Tertiary syphilis is very serious and will typically occur 10 to 30 years after the initial infection. In the tertiary stage, the disease damages your internal organs and can result in death. When diagnosed and treated in its early stages, syphilis is easy to cure. The preferred treatment at all stages is penicillin, an antibiotic medication that can kill the organism that causes syphilis. A single injection of penicillin can stop the disease from progressing if the infection is less than a year. If longer than a year, additional doses are required for treatment to be effective. Penicillin is the only recommended treatment for pregnant women with syphilis. If a pregnant mother is treated for syphilis during pregnancy, the baby should also receive antibiotic treatment. People who are allergic to penicillin can be treated using other antibiotics, e.g., doxycycline. Sexual partners should also seek treatment in order to avoid spreading the infection. The best way to avoid syphilis infection is through sexual abstinence. However, prevention can be achieved by restricting sex to one uninfected partner and using condoms consistently and correctly. Pregnant women should be tested for syphilis during pregnancy, and if they test positive, should be treated to protect the unborn baby. People with syphilis should refrain from any sexual contact for at least 1 week after completing treatment or until the lesions of early syphilis are fully healed. We now move to discuss donor counseling. Donor counseling is a confidential dialogue between the counselor and a blood donor before or after giving blood, which enables a donor to make an informed decision. Counseling done before giving blood is aimed at identifying unsuitable blood donors so that they can be counseled and deferred. The counseling process, correctly approached, is a key part of donor care and helps improve donor retention. The counseling process is made up of different stages, from pre-donation information, pre-donation counseling, and post-donation counseling. The group pre-donation information is usually given at schools, colleges, and workplace to groups of prospective blood donors by donor recruiters. Pre-donation information may be provided orally through printed material or using audiovisual aids. Before a donor comes in for counseling, it is important to prepare the room. Equipment and documentation to be used during the screening, including deferral registers and risk assessment questionnaires, should be to hand. When the potential donor walks in, offer him or her a seat and make sure they are comfortable. Establish rapport. Relationship building begins when a counselor meets the client for the first time and continues throughout the session. The way the counselor welcomes a potential donor, the body language, tone of voice, and all aspects of communication assist in establishing a relationship that will determine to what extent the client will open up and share information. Pre-donation counseling is a confidential interview done to establish medical history and assess the risk of exposure to TTIs. The interview is aimed at protecting both the donor and the recipient. Hence, it's important to establish what the donor understands by safe donation, for example, through checking knowledge of the window period. Explain the procedures involved in blood donation, probe on risk factors, and offer the prospective donor an opportunity to self-defer. You are assessing the prospective donor's suitability to donate blood against specified criteria on your health assessment questionnaire, as well as giving information helpful to the donor. Discuss their lifestyle, including social habits, sexual relationships, and condom use, establishing any previous exposure to HIV. Discuss the blood donation procedure and highlight the tests done on donated blood and why. Explain your notification and referral systems. Probe for and be sure to correct any myths and misconceptions on the part of the donor. Finally, you must obtain informed consent. In this slide are conditions and medications that could indicate unacceptable risk to the recipient and which may definitely or possibly lead to deferral. These include malaria, HIV and AIDS, antibiotics, and unexplained weight loss. Donor deferral is the deferral of a prospective blood donor from donating blood after medical, health, or risk assessment. Deferral can be temporary or permanent. When counseling a donor, always use simple language which the donor can understand, avoiding medical jargon. Address any concerns and be sensitive to their feelings, acting in a professional manner and not rushing the donor. Unsuitable donors should be provided with appropriate support, including a referral system if there is need. Inform the donor as to whether the deferral is temporary or permanent, clearly explaining the length of the deferral if temporary. Having a mechanism in place that can follow up the prospective donors once the deferral period has expired is considered good practice. It is also helpful to explain any lifestyle changes that may be beneficial. For instance, listing iron-rich foods in the case of low hemoglobin. Post-donation counseling should be offered to all blood donors after blood donation, regardless of the test results, but it is in the case of positive results that the dialogue between counselor and donor becomes most critical. The objectives of counseling in this instance are to help the infected and affected handle possible emotional reactions, signpost and encourage adoption of appropriate courses of action, and promote healthy lifestyle changes. As a counselor, you should be aware of your own psychological state as you prepare for the meeting. The following are considerations for a successful counseling session. Use a private room with minimal disturbances. Put a "Do Not Disturb" sign outside the door. Make sure you have the correct results available. Seating arrangement should not create a barrier, so avoid sitting behind a desk if you can. Introduce yourself and state the time allocated for the session. Discuss the issue of confidentiality and its limitations. Agree on a language to use. Assess the donor's readiness to receive results. And if the client is ready, give the results. Give the test results in a neutral voice as soon as possible to avoid tension building up. Then pause to let this information sink in whilst you keep your eyes on the client. Check for cognitive understanding of the result, especially in the case of a positive result. Give time for any emotional reactions, and if these occur, reassure the donor that any combination of shock, anger, disbelief, and blame are quite common. Identify what difficulties the donor foresees and how he or she might deal with them. Give information, demystify myths, and correct misconceptions. Check knowledge about their understanding of transmission and prevention. E.g., what do you remember from the pre-donation discussion about the test result? Give consistent facts about transmission and prevention. Discuss disclosure. Encourage the donor to make healthy lifestyle choices. For example, they might be encouraged to eat a balanced diet, stop or cut down on smoking, and not to take or limit the amount of alcohol. It is also important to avoid spreading any disease by practicing safe sex. The donor should also be encouraged to maintain good hygienic practices, avoid stress, and ensure they have enough rest. Be sure to refer the donor to other healthcare professionals for further management. This may also apply to any household or sexual contacts. Please use these prompts to help you reflect on what you have learned. In Module 4, we will look at donor education, recruitment, and retention.